I'm Dr. Fakir Ravari, and this is Portal Hypertension and Cirrhosis Part 2. First, introduction to hepatitis A virus. As you may know by now, any type of hepatitis can lead to cirrhosis over a long period of time, including hepatitis A. Hepatitis A is actually transmitted in a fecal oral route and also from the oral anal sex. So once the virus has orally been ingested, the virus reaches the host liver and then it causes hepatocyte injury, which over time can cause cirrhosis. Hepatitis B virus is actually one of the most common causes of cirrhosis because of its prevalence worldwide. What's special about hepatitis A and hepatitis B is that we have vaccination for both of these, whereas hepatitis C we currently do not have any vaccination for. So hepatitis A and B are preventable. The first learning objective for today is, given a cirrhotic patient with ascites, evaluate acidic fluid laboratory data. Now, what exactly is ascites? So ascites is the pathologic accumulation of peritoneal fluid. So in this picture, on the right hand side, you can see that we are looking at the patient sideways. So you can see here's the liver and here's the peritoneal space. So fluids will come out of vasculature in advanced cirrhosis. This is one of the decompensations of cirrhosis. So in advanced cirrhosis, fluid will come out of leaky vasculature and enter the peritoneal space over here. One of the main reasons for this is because in advanced cirrhosis, the patient's albumin levels will be low. One of the things about albumin is that it's in the blood, and what it does is that because of its osmotic pressure, it will hold on to fluids. Now, when someone does not have normal levels of albumin, there's not enough osmotic pressure, so fluids tend to follow osmotic pressure, so they actually escape the vasculature. So that's important to know because we can actually give these patients albumin. So understanding that will help you. Now, this will be covered in more details in a couple of weeks in Patient Care 1 when you guys cover electrolytes and fluids. Now, the complications of cirrhosis that are considered decompensations include variceal bleeding, ascites, and hepatic encephalopathy. And ascites is actually the most common complications when it comes to decompensated cirrhosis. And this is one of the most common reasons for patients to end up in the hospital. Ascites is associated with poor quality of life, increased risk of infections, and renal failure, and poor long-term outcomes. In fact, there is something referred to as hepatorenal syndrome. So this is basically a functional renal impairment that occurs in advanced cirrhosis. And this is basically because, when patients have ascites and all these fluids are coming out of vasculature, there aren't enough volume left in circulation. So as a result, you start to have low perfusion to the kidneys. So even though the kidneys may not specifically, so the kidneys may actually be normal, but because of diminished renal blood flow, you get renal failure. And because this is due to the, hepatic failure, this is together referred to as hepatorenal syndrome. Now, when patients develop hepatorenal syndrome, unfortunately, the mortality rates are very high. There are two types of hepatorenal syndrome. However, we're not going to talk about them because that's beyond the scope of this course. So the most important diagnostic evaluation to do when patients develop ascites is to perform diagnostic abdominal paracentesis. So basically, they will use a needle and draw about 30 to 50 ml of fluids from the acidic fluids. And once you get these fluids out, just a small volume, because this is meant for diagnostic purposes, you can do analysis of the fluids. So you can send it to the lab, in several bottles. So you can send it to check for appearance. So if these fluids are not infectious, they're supposed to be clear. Whereas if it's infected, it can be cloudy or turbid. It can also appear milky if there's a lot of triglyceride in there, which because not all ascites are due to cirrhosis, but if it is, for example, if it's due to biliary problems or pancreatitis, it can actually have triglycerides in there. So that can distinguish for other reasons. And of course, if it's bloody or if it's really dark, it can mean different things. Of particular importance is the ratio of serum ascites albumin gradient. So what this means is that once you get that fluid and you send it to the lab, they will tell you how much albumin is in the fluid. You can also check the albumin in the serum. So normally normal serum albumin is about 3.5, which will be lower in this patient. So whatever this patient's serum albumin is, and then you subtract whatever albumin is in the acidic fluid, and then the difference will be the SAAG, or serum ascites albumin gradient. Now this will tell you a lot of information. So if this number is depending on what units your laboratory uses to report these numbers. For example, Clovis Community reports this in grams per deciliter. So if the gradient is greater than or equal to 1.1, this indicates that the patient has portal hypertension. So that's the most common thing that they do when you get acidic fluid. Another thing that you can do with it, you can actually get cell count and differential. So if you get the PMN of at least 250 cells, this means that there's spontaneous bacterial peritonitis. So that means that you have bacterial infection in here. I will talk more about spontaneous bacterial peritonitis, or SBP, in another later in this video. And then, of course, last thing is to get bacterial culture. And bacterial culture will take 2 or 3 days to get the results from, whereas the cell count you can know immediately. So once you know that PMN is elevated and you have bacterial infection here, SBP, you can start empiric treatment with antibiotics, and then 2 or 3 days later with the cultures you can know exactly what organism is growing in there, and then adjust antibiotic therapy. The next learning objective is, given a cirrhotic patient with ascites, recommend appropriate management of ascites. So once portal hypertension, when you get these changes in physiology, as I mentioned, vasodilation makes these arteries to be leaky. So increase in capillary pressure results in lymph formation that exceeds lymph return, and then these fluids collect in the peritoneal space. So vasodilation, in the portal system just results in more blood going there, so the pressure increases. Whereas that same vasodilation in the normal systemic arteries, results in arterial underfilling. So that would activate vasoconstrictors and anti-natriuretic factors. So once you get these factors released, then you will have sodium and water retention. So if you have sodium and water retention, then you have expansion of plasma volume, so that continues to add fluids to the ascites. And then the other things that can vasoconstrictors and anti-natriuretics do is that they can impair free water excretion. So these patients typically have hyponatremia. And then it can also cause renal vasoconstriction, so patients can get something referred to as hepatorenal syndrome, which is beyond the scope of this topic. I will not talk about hepatorenal syndrome. So what should we do for patients with ascites? So first line treatment, of course you need to know that SAAG to begin with, because if the SAAG is low, like less than 11 grams per liter, patients typically don't respond to these first line therapies. But for those who have SAAG greater than or equal to 11, one of the most important things is cessation of alcohol use. Assuming if they have alcoholic cirrhosis, then dietary sodium restriction is very important. So we do want to restrict sodium to 2 grams a day, 2,000 milligram a day. That's fluid restriction is not necessary unless sodium is less than 125. In fact, chronic hyponatremia in cirrhotic ascites patients is usually not morbid unless it is rapidly corrected at the time of liver transplantation, for example. So if they have mild hyponatremia, it's not reason to have fluid restriction. Fluid restriction typically doesn't work. Now, what they really need to be on is dual diuretics. Really, we're not. The reason we're using diuretics is not so much for the diuresis, because we're not really trying to get rid of the fluids, but rather it's for their natriuresis. So we're trying to get rid of sodium. Typically, we give them dual diuretics in the morning. Giving them in the morning, it not only improves adherence, but it will also avoid nocturia, so they don't have to wake up. Patients don't have to wake up in the middle of the night to pee. The most commonly used regimen is spironolactone and furosemide, and you have to use this in a ratio of 100 milligram to 40 milligram. So spironolactone 100 milligram and furosemide in 40 milligram, and you can titrate the dose. You can increase the dose every 3 to 5 days, but you have to maintain this ratio. And the reason we have maintained this ratio is because we're trying to get rid of sodium. But we want to make sure that potassium stays, the same. So if you have potassium-sparing diuretic, if you use this combination in this ratio, it will hopefully maintain potassium at the same levels. Another thing that's recommended for this patient is albumin 25 gram weekly for 1 year, followed by infusion every 2 weeks. Which has been shown to improve survival compared to diuretics alone. So, in addition of spironolactone and furosemide, you can also consider albumin. And of course, as I mentioned earlier, if the patients are NSAIDs, it should definitely be discontinued if they have ascites. So NSAIDs can also cause, retention of fluids and sodium in the body. So because NSAIDs also act on the kidneys, so they should definitely be discontinued. Anybody with cirrhosis who has ascites should not be on NSAIDs, with the exception of a low-dose aspirin. And so ultimately, these patients will need to be evaluated for liver transplantations, because at this point, these patients are decompensated, so they will need liver transplantation. Yeah. So another option that we have for treatment of ascites is therapeutic abdominal paracentesis. So with dual diuretic, there's only so much fluids you can get rid of. So there's a certain limit at some point. So there's a limit on how much the kidneys can actually get rid of fluids. So if someone has so much fluids that diuretics are not enough, then you can actually physically remove the fluids. So this is different than diagnostic abdominal paracentesis. So diagnostic, you typically take like 30 to 50 milliliters, whereas with therapeutics we're talking about liters of fluid. And it's usually based on how much weight the patient has gained. So for example, someone who has recurrent ascites, so if if they get discharged from the hospital and then 2 weeks or a week later they come back and they say, okay, I gained I'm sorry, if they say they gained 10 kilos, 10 kilos. So 10 kilos translates to 10 liters of fluids. So if they say, I gained 10 kilos, then that means that they have gained 10 liters of fluids. So it's hard to get rid of 10 liters of fluids just using diuretics. So what typically happens is that they actually draw the fluids out. For example, they could get 10 liters. Now, this can be dangerous because once you remove these fluids out of the abdominal, or I should say from the peritoneal space, the body wants to, refill it because you just changed the body. So if you remove these fluids, the body will try to fill the peritoneal space again, which means that that fluid will come from circulation. So that can be dangerous because if the body takes all the fluid out of circulation to fill the peritoneal space, the patient's blood pressure will drop and potentially the patient can go into shock. So up to 5 liters of fluid is pretty safe, so you can easily draw 5 liters without endangering the patient. But beyond 5 liters, it becomes dangerous. So what they typically do is that they will actually administer IV albumin. And it's recommended to do about 6 to 8 grams of albumin for every liter in addition to the 5 liter that's being removed. So for example, if somebody was removing 6 liters out, so the first 5 liters is okay. For the extra liter beyond 5 liter, you will just administer, for example, 6 grams of albumin. Or if you were, removing 8 liters of fluids, so you have 3 liters in addition to the 5 liters. So 3 times 6 is 28 grams. So you will administer about 28 to 30 grams of IV albumin. And the reason is you will administer albumin into the circulation, and the osmotic pressure will hold on to the fluid. So as you draw all this fluid out of the peritoneal space, this albumin will hold on to the fluids in the blood vessels, so that it will not try to escape and fill the peritoneal space. So the osmotic pressure from albumin will help hold on to the fluids so that the patient will maintain their blood pressure. The next learning objective is, given a cirrhotic patient with ascites, recommend treatment and prophylaxis measures for spontaneous bacterial peritonitis, or SBP. Another thing that can happen with patients with ascites is something referred to as spontaneous bacterial peritonitis, or SBP. So SBP involves translocation of bacteria from the intestine to lymph nodes with subsequent bacteremia and infection of ascitic fluid. Unfortunately, SBP has a high mortality rate. The most severe complication of SBP is the hepatorenal syndrome. So it's been, it's recommended to use IV albumin 1.5 gram per kilo of body weight at diagnosis, and then do 1 gram per kilo 48 hours later. So that would be on day 3. It helps to prevent the hepatorenal syndrome and improve the probability of survival. Suspicion for infection includes abdominal pain or tenderness, fever, encephalopathy, renal failure, acidosis, or peripheral leukocytosis. So actual diagnosis of SBP is once you get ascitic fluid and you get a PMN of at least 250. That would basically confirm SBP. Now, if the PMN is less than 250, but if the patient has a fever of at least 100 degrees Fahrenheit or abdominal pain, that can also confirm diagnosis of SBP. What typically causes SBP is aerobic gram-negative bacilli, most commonly E. coli that comes from the gut. So for empiric treatment of SBP, we typically use IV third-generation cephalosporins. The guidelines, which are from 2012. They recommend cefotaxime 2 gram every 8 hours because we have a lot of data with it. There's also some data with ceftriaxone 1 gram every 12 to 24 hours, and that's what typically is used in clinical practice. So ceftriaxone is easy to dose, and it can potentially be dosed once a day dosing. So that's easy to do. It's not renally adjusted, so ceftriaxone is what we use in clinical practice. Now, if someone gets SBP from the hospital, you should use your local antibiogram to guide therapy, especially if someone has had recent beta-lactams, just to make sure that if they have potentially drug-resistant E. coli, such as ESBL producing E. coli, for example. Alternative to ceftriaxone or third-generation cephalosporin is oral fluoroquinolones. And the total duration of treatment is 5 days. So that includes both empiric window and also definitive therapy. So if you get the cultures back and if you streamline antibiotics, total duration of therapy should be 5 days. So once someone gets SBP, we want to make sure this doesn't happen again. So we do have SBP prophylaxis, especially if someone has, if someone develops new ascites and they don't have, if you don't have suspicion for an infection, you can still do you can do SBP prophylaxis. So we use the same antibiotic ceftriaxone for 5 days. And then for patients who actually had SBP and you want to do secondary prophylaxis, you should use long-term. You can potentially do long-term. There's limited data, that's why I say potentially. So one recommended agent is ciprofloxacin once weekly. So by long-term, I mean you just continue this for life. The 5-day regimen is for patients who just newly developed SBP. Ascites. So if someone just developed ascites and you want to do prophylaxis for SBP while we manage the ascites, you just do 5 days of antibiotics, just to make sure they don't have SBP, since the mortality rate is high with SBP. Now, someone who did have SBP, you want to treat them with either Bactrim, Trimsulfa, or Cipro for potentially for life. The next learning objective is: given a cirrhotic patient with hepatic encephalopathy, recommend appropriate management. Hepatic encephalopathy is a frequent complication of one of the most debilitating manifestations of liver disease. By definition, hepatic encephalopathy is a brain dysfunction caused by liver insufficiency and/or portosystemic shunting. It manifests as a wide spectrum of neurological or psychiatric abnormalities, ranging from subclinical alterations to coma. Now, the pathogenesis, it typically involves fibrotic liver, prevents flow of blood through liver for processing. So less NH3 is filtered through the liver. It means that less of it is converted to urea. So ammonia, NH3 is ammonia, continues in circulation, and at high levels it can actually cross blood-brain barrier, leading to altered mental status. So this altered mental status is largely due to ammonia. So in the colon, what typically happens is that we do have these normal flora, so bacteria that normally reside in the colon, and they have the job of converting proteins, like as part as protein metabolism, to ammonia. So because ammonia is a byproduct of these normal flora, ammonia gets absorbed into the into the system. And in a normal, in a normal person without cirrhosis, this ammonia goes into the liver and is converted to urea. So it doesn't really cause any problem. The problem is if someone has cirrhosis and their liver is not capable of urea cycle to process ammonia, this ammonia will accumulate in circulation, and then at high levels it can cross the blood-brain barrier and go into the brain. And into the brain, it is neurotoxic and it can cause abnormally functioning neurons, which results in altered mental status and hepatic encephalopathy. So this is what happens in the chronic liver disease such as cirrhosis. Now in the acute setting, it can also cause brain edema. So this happens in someone who develops like acute liver disease, but what we see in chronic liver disease such as cirrhosis is hepatic encephalopathy. Now for therapy for episodes of overt hepatic encephalopathy, we do recommend lactulose as first line. So the way we use lactulose is initial dose of 25 mL of lactulose syrup every 1 to 2 hours until at least 2 soft or loose bowel movements per day have achieved. And then we can titrate it to maintain 2 to 3 bowel movements per day. The way lactulose works, it actually is kind of like a prebiotic, so bacteria will actually use it, and they will degrade lactulose. As a result, it actually makes the pH of the gut very acidic, and under acidic pH, ammonia will actually be converted to ammonium, so ammonium will have a positive charge, and because of that, it will not be absorbed from the gut into the portal system. So that helps in reducing the ammonia levels in the body. Another thing that it does, as part of that change in pH, it actually enhances diffusion of ammonia from the blood to the gut. So it also, takes some of that ammonia from the blood and take it into the gut. And then the last thing lactulose does, it actually produces an osmotic effect, which is responsible for the bowel movements. Another agent that we have that we can use is rifaximin. It is an effective add-on therapy to lactulose. So we have to add it to lactose because when they studied this, so this was lactulose plus rifaximin. It wasn't rifaximin alone. So it's very effective in prevention of overt hepatic encephalopathy recurrence. Other things that we have limited data for is, for example, oral branched chained amino acids. They can be used as an alternative or additional agent to treat non-responsive patients, especially if patient cannot tolerate, lactulose or rifaximin because of, diarrhea or, rifaximin is expensive. We also have limited data for IV LOLA or ornithine L-aspartate. It can be used as an alternative or additional agent, just like branched-chained amino acids. Neomycin is an alternative choice for treatment of overt hepatic encephalopathy, and lastly, metronidazole is an alternative choice. Now, the way rifaximin works, it actually is an antibiotic. It's rifamycin, and it's not. It's an oral agent that's not absorbed. So if it's not absorbed, stays in the gut, and it kills some of those bacteria. So by killing the bacteria in the gut, it will prevent the formation of ammonia. So the same is true for metronidazole and neomycin, but these are systemically absorbed. So we prefer rifaximin because it's not systemically absorbed. Because if they're systemically absorbed, then it can affect other flora in your body. So this is for treatment, and then once someone has hepatic encephalopathy, we want to prevent that from happening again. So we have prophylaxis, secondary prophylaxis. So we do continue this patient with lactulose. We can also add rifaximin as an add-on to prevent this from happening. And we have very limited data when it comes to prevention of hepatic encephalopathy. The last learning objective is recommend hepatitis immunization to patients at risk for liver disease. So of course, hepatitis is the most common preventable infection that can lead to cirrhosis. The CDC actually recommends a 3-dose series of single antigen Hep B, and we have 2 different products for it, Engerix B and Recombivax HB, or a 3-dose series of the combination of Hep A and Hep B. So the combination product is called Twinrix. So anytime there's Hep B in it, you need a 3-dose series. So who exactly is it indicated for? So definitely anybody who wants to protect themselves, they can actually get it. So if anybody says, you know, I just want to be protected, they can definitely get Hep B. Especially if you're traveling internationally. But more importantly, adults with chronic liver disease. So if someone has cirrhosis, they definitely need to get the Hep B vaccine. Including if somebody's ALT and AST has been greater than 2 times the upper limit of normal. It's also indicated for patients with end-stage renal disease. So those patients will be on dialysis. And because they are at, anybody who's on dialysis is at increased risk of getting other hepatitis infections and as well as HIV. So they should be protected against Hep B. For Hep C, it's also in fact, before we start treatment for Hep C, it's recommended that patients get vaccinated for Hep B and also be screened for Hep B infection before you initiate treatment for Hep C. And also for HIV infection, it's also indicated. Now, if someone is pregnant, they should get the Hep B only if they are at risk of getting Hep B during pregnancy. Otherwise, if they don't have any risk factors for getting Hep B, it should be delayed until after pregnancy, because the two vaccination that everyone should get during pregnancy is just the flu shot and the Tdap. Otherwise, Hep B is not contraindicated, but if the person is not at risk, then it's best to just delay it until after pregnancy to be safe. And other people who are at risk of getting Hep B includes lifestyle. So, for example, sex workers, people with multiple sex partners, and men having sex with men, as well as injection drug users. The CDC also recommends vaccination against hepatitis A. We have 3 products. So if it's just a Hep A in it, there's just a 2-dose series. Whereas if it's a combination of Hep A and Hep B, because of the Hep B part, it should be a 3-dose series. So the combination is Twinrix. For Hep A, we have Havrix and Vacta are the 2 products. Who exactly should get it? Again, anybody who wants to be protected can actually get it. Especially adults traveling to countries with high or intermediate levels of endemic Hep A infection. And some special population that the CDC recommends this for includes, again, chronic liver disease. So if someone has cirrhosis, they should definitely get immunization against hepatitis A as well. Also, patients who receive clotting factor concentrates, as well as men having sex with men, or MSM for short. Also patients who use illicit drugs, as well as those who work with Hep A infected primates, or if they work in a research setting for Hep A. This concludes this presentation.